Well, hello there. This is Professor White, and this lecture is going to be on the respiratory drugs. All right, so the respiratory system literally has one function within our body, and that is to do the oxygen exchange for carbon dioxide. So it's going to give oxygen through the alveoli, the capillary membrane, to circulate within the body and offload the carbon dioxide. So that is its one job. Now we do have two separate areas of the respiratory system, and that would be the upper respiratory and the lower respiratory. Now the upper respiratory does have some more functions with the air that we breathe, in that has a bit of a filter, warms and humidifies the air that comes through. But again, all of that is to get to the purpose of oxygen exchange. So the upper respiratory tract is those structures which are outside of the chest cavity or the thorax. And these are including things like the nose, the narrow nasopharynx, oropharynx, laryngopharynx, and the larynx. So everything up into including the larynx is considered the upper respiratory tract. So the lower respiratory tract is the trachea on down and terminating with the alveoli, which is the point of gas exchange. So the alveoli are the functional unit of gas exchange within the respiratory system. In the previous section, we spoke about those sort of disorders that affected the upper respiratory tract more. And now for this one, we're going to talk a bit more about those that impair the lower respiratory tract. So this would be things like asthma, COPD, things of that nature. COPD is a very common disorder, and you will see this in many patients. It's definitely related to smoking, though there is a form of COPD that is more genetically based. However, again, most of them are going to be related to a history of smoking. So COPD is chronic obstructive pulmonary disease. And basically, it's kind of like what we used to call emphysema with a chronic bronchitis component. So there's things that you'll learn about in your patho courses that will explain COPD a bit more to you. But basically, we have an issue with obstruction of the lung airflow that interferes with normal breathing, increased mucus production, and decreased surface area for oxygen exchange. And it is not reversible. All right, so let's keep talking. Chronic bronchitis is basically inflammation and sort of like a subacute infection of the bronchi. So we're going to have inflammation and mucus production and changes in the bronchial structure. So chronic bronchitis is basically a component of COPD, though. So basically all patients with COPD would have chronic bronchitis, but all patients with chronic bronchitis may not have COPD. Basically, exposure to bronchial irritants. So you can see here, I have a picture that's actually of a narrowed airway with the mucus production in it. Now, whereas COPD and emphysema, which we'll talk about in a minute, are not reversible, bronchial asthma is reversible. There are 4 different categories of asthma. There's the intrinsic asthma, which is in patients with no history of allergies. Extrinsic, those with allergies. Exercise-induced, so those people, when they start to exercise, they would potentially have asthmatic symptoms. And drug-induced. So basically, in bronchial asthma, what happens is that the alveoli remain open, they remain functional, but there's not any airflow to them, or it's obstructed. And as a result, the patient ends up with wheezing and difficulty breathing. So I think it's a good spot here to basically talk about some of the other patho here. So remember, once our airways are narrowed, the patient suffers inflammation, which causes an increase in mucosa production, and that mucus is very, very thick. Status asthmaticus is a medical emergency. It is a prolonged asthma attack that does not respond to the typical drug therapy and can last for several minutes to hours. And I have some of the signs and symptoms in here of a patient who is unable to speak. They have silent chest. Remember, the airways are closed up, so you're not going to hear potentially breath sounds. I'd rather hear wheezes than nothing, honestly, guys. Bradycardia. Basically, this can lead to death on a patient, so pay attention that this is a medical emergency. All right, so emphysema. Emphysema is actually a part of COPD. I don't think we're really using the term emphysema anymore, but to think about COPD in the lines of the fact that these alveoli, in order to get good surface area, they actually like a whole bunch of little grape-like structures, and when you have destruction of the alveolar wall, it leads to this enlarged area but decreased surface area. So basically, the patient isn't able to offload the oxygen or the CO2. All right, so let's get into a little bit of the pharmacology that we need to discuss. So bronchodilators are a mainstay of treatment for things like bronchial asthma as well as COPD. There are more medications that fall into different categories, but we'll start with the bronchodilators. And that's because, you know, that's a real big part of treatment of these disorders, is opening those airways. And some of our other treatments really work on decreasing inflammation and some other issues. So bronchodilators, what they do is they relax that bronchial smooth muscle, which gives us dilation. And there's 3 different classes. We have the beta-adrenergic agonists, we have the anticholinergics, and then the xanthine derivatives. Doesn't matter what sort of drug you're talking about. If it's a bronchodilator, we are looking for the therapeutic effect of bronchodilation, which is increased ease of breathing. We want our patients to breathe better. All right, I think it's really important here to talk a little bit about the different types of bronchodilators, and we'll get into a little bit more patho in just a minute here. But there's 2 main classes that you have to be worried about. One is the short-acting beta agonist, or the SABA inhalers, and these would be things like albuterol, which you should be potentially familiar with, levalbuterol, and some of the other ones that may not be used as frequently but fall into the same class. But again, our prototype is going to be albuterol. So these short-acting beta-adrenergic agonists, these are your rescue inhalers. Now, they're used for other reasons, but this is the one that we're going to reach for in the case of an acute episode of something. So what we do is we use them to reduce airway constriction quickly and restore airflow to normal levels. So they are sympathomimetics, and again, used for acute issues. Our long-acting beta agonist inhalers are never, ever, ever, never used for acute treatment. So these are not going to be what's going to stop an acute asthma attack. Some of the common ones that you'll see would be salmeterol, formoterol, and some of the newest ones. We're having a lot of combination drugs that are coming out, so we might have a Breo ellipta. And when we see ellipta, I have it written here, but it refers to the new delivery system. So you might see Anora ellipta. Just understand that it's just marketing. It's the name of the delivery system. So remember, short-acting is for a serious short onset issue, and long-acting is for our non-acute events. All right, so I have a picture here that I'm hoping will help you remember where some of our receptors are in the body. You have 1 heart and 2 lungs. So our beta-1 receptors are found basically in cardiac muscle, while beta-2 is in the lungs. Alpha receptors are basically found in the vessels. So as you go through your nursing career, try and keep those in perspective, where alpha is, beta-1, and beta-2. And that's important as we look at how these medications work and sort of like what they do, their mechanism of action. So our non-selective beta adrenergics, this would be things like epinephrine, so the EpiPen, stimulates alpha, which is in the vessels, beta 1, which is in the heart, and beta 2, which is in the lungs. So that's why that medication is very, very helpful in cases of that. Non-selective beta means that they stimulate both beta 1 and beta 2. And then selective beta 2. So these are going to stimulate only the beta 2. So you're going to see them, the action in the lungs. Now this doesn't mean that they're not going to potentially have some stimulation and like increased heart rate, tachycardia, because they are sympathomimetics, but their main action is going to be there. And to wrap it up then, basically the mechanism of action is based on the specific receptor that is stimulated. And at the end of the day, what we should have is dilation of the airways. There's also a little blurb here on what CAMP does, which is cyclic adenosine monophosphate. I don't think it's need to know, but I think it's good that you know a little bit of the patho behind it. So if you see that word CAMP, you know what it's referring to. So beta adrenergics are used to relieve bronchospasm in the case of asthma and COPD and some other disorders. It's used for treatment as well as prevention. And also these are used in hypotension and shock, and that's because of the effect of alpha. Now contraindications would be, of course, an allergy to the medication, somebody with uncontrolled hypertension. And think about what these drugs are doing. They're sympathomimetics, so they are going to potentially cause increased hypertension. They can cause cardiac issues, so somebody with known cardiac dysrhythmia would be more at risk for them. And then a high risk of stroke, right? So because of the vasoaction, so alpha constriction. Now let's take a look at some of the adverse effects. So those that work on alpha and beta, so epinephrine would be the one. These are the potential adverse effects: difficulty sleeping, restlessness, anorexia. So this is a sympathetic nervous system overdrive. Increased blood sugar or hyperglycemia, tremors. People feel anxious and have the tremors after receiving these medications. And of course, cardiac stimulation in the way of increased heart rate and potentially cardiac ectopy. Now the adverse effects of the beta 1 and beta 2. Again, beta 1's in the heart, so you're going to see more cardiac stimulation here. And beta 2, again, albuterol is our exemplar drug. It can have a decrease in pressure or an increase, a headache, and tremor. Remember, things like nervousness and tremor, cardiac stimulation, they're all possible and expected effects of beta agonists. Beta blockers may impair the ability for these medications to work, so you might not get as much bronchodilation on a patient who's on a non-selective beta blocker already for some cardiac issues, whether it be dysrhythmias or hypertension. Of course, there's interactions with MAOIs. Other sympathomimetics, because they're doing the same thing, you can have an increase in the sympathetic response. And because of the increase in blood glucoses, you want to make sure that you're monitoring your patients with diabetes closely when they're on these medications. Okay, so let's take a look at albuterol, which is one of the short-acting beta-2 agonists. It is beta-2 specific. It is the most commonly used drug that will be in this class, so it is must-see TV for you guys. So here's some things about it. You cannot use it too frequently because in the case that it is used too frequently, you're going to have an increase in those systemic effects. And if that's the case, you may also have a loss of the beta-2 effect. So you're not going to be seeing the same therapeutic response of the increased ease of breathing in the patients with it. Now, albuterol is available orally and inhaled, but inhalation will be the most common way that you will get this medication to patients. And that may be using a metered dose inhaler or a puffer, or it may be using a solution for a nebulizer, so an inhaled solution. In practice, I will say that most patients who are outpatient and doing their own thing using rescue inhalers and such, that they're using this in a puffer way, like a metered dose inhaler, and our hospitalized patients in general will be getting the nebulized solutions. And you'll see a lot more nebulizers among small children, and that's because of their inability to meaningfully coordinate their breathing with the metered dose inhalers. I should also mention that in the case of severe asthma attacks where a patient may come to the hospital versus being treated at home, we'll often use albuterol along with like a systemic corticosteroid, really to knock down that inflammation and get the patient feeling better. Now let's talk about the long-acting. So this would be your exemplar out of the LABAs, which is salmeterol or Ceravent. So this is a long-acting beta-2. It's a bronchodilator. Again, we never use those long-acting for acute treatment of any disorder. This is often given in combination with another corticosteroid called fluticasone. And the use of this medication really is for COPD and asthma, and it's for maintenance treatment. So again, not for an acute attack of anything. Remember, salmeterol should never be given more than twice a day, and you should not exceed the maximum daily dose of 1 puff twice a day. Okay. So next, let's talk about the anticholinergics. So anticholinergic medications, these block the action of acetylcholine, and acetylcholine causes bronchial constriction. So by blocking that action, prevents acetylcholine from binding to the receptors, and as a result, it's not able to cause the bronchoconstriction. So this is very useful in our patients with COPD and also in asthma. When we're giving patients nebulizing solutions with COPD in the hospital, remember I work with adults, so my frame of reference is generally adult patients. We're usually giving them Duoneb, which is a combination of albuterol and ipratropium bromide. And that makes sense. So we're giving them the bronchodilator and then one that's blocking the acetylcholine. But we also have these available in other forms as well. So it could be an inhaler, tiotropium. And again, indications are prevention of bronchospasm for chronic bronchitis and emphysema, but not for an acute treatment. Let's look at our adverse effects. So anticholinergic drugs, they basically make it so that the patient can't spit, can't pee, can't see, and can't poop. Also might cause some GI distress, headaches, coughing, and anxiety. The exemplar drug out of here is going to be ipratropium. So it is the oldest and most commonly used one, available for inhalation as a metered dose inhaler and also as a nebulizing solution, usually twice a day, like I said, and then some of the others that you may see in here, so tiotropium, etc. All right, so let's go on to the xanthine derivatives next. All right, so as we talked about that CAM system before, xanthine derivatives increase the levels of SAMP, and basically it's by blocking phosphodiesterase. So phosphodiesterase is an enzyme that breaks down CAMP, so if we inhibit that, CAMP gets to stay more active. So that results in smooth muscle relaxation, bronchodilation, and increased airflow. So these can be caffeine, theophylline, aminophylline is a synthetic form, but for us only theophylline is used as the bronchodilator. So what do these drugs do? So basically cause bronchodilation by smooth muscle relaxation. They can also stimulate the central nervous system, which is why These medications like caffeine and such are used for neonates who have sort of that decreased respiratory drive. Also can cause a positive inotropic effect on the heart, as well as a chronotropic effect, and can cause the kidneys to be better perfused. So here on this slide, you can pause and take a look at the indications and contraindications, but of course it's indicated for chronic bronchitis, emphysema, COPD, asthma. Again, not for management of an acute asthma attack. We're going to stick with our short-acting beta agonists for those. And contraindications, it is ulcerogenic, so those already with peptic ulcer disease would be a contraindication. And very careful use in cardiac disease. And something special here, that cigarette smoking enhances the metabolism, so you might not get the effect that you need with this medication. Numerous adverse effects, including GI effects, increase GERD symptoms, especially while sleeping, can cause changes in the cardiac rhythm, increased urination, high blood sugars, lots of interactions, and then also some food interactions. Anything that's like charcoal broiled, high protein, basically may reduce the levels, so make that medication is not as therapeutic. We sort of already talked about caffeine being used in neonates because of those that might need an increase in their drive, and also if they have low heart rates. A lot of times people use this without a prescription, and you may be one of those. If you're studying these medications right now, trying to stay up and get all the information, perhaps you're taking the caffeine pill itself, or maybe you're taking beverages in that have a lot of caffeine. You're not going to see theophylline used very much in the clinical setting. There are cases where you will, but the reason for that is because you need to have very specific blood levels, and for us the therapeutic range is going to be 10 to 20, though it's usually being advised now 5 to 15, with toxicity displayed in levels over 20. Aminophylline may be used in patients with status asthmaticus if they're not responsive to the beta agonist, like if they're not responsive to epinephrine, etc. But again, although not commonly used, theophylline is still seen clinically, so you should be aware of it. Now let's move on to some of the things that aren't really bronchodilators, but they affect the respiratory system. And one of those is the leukotriene receptor antagonist. So these are the most common you're going to see is montelukast or Singulair. We can also talk about the corticosteroids and mast cell stabilizers, which are not used very often. All right, so here's a picture of Singulair. I've always been partial to this because I like interestingly shaped pills. It gives me a little bit of diversity in my day for passing medications. So leukotriene receptor antagonists, they are indicated for chronic, not acute asthma. Okay, you take them every single day. So when our patients are being taught about these meds, they're to be taken every day, even if their symptoms improved. And they are only available orally. And these really work by blocking leukotrienes, which those leukotrienes, they're icky. They cause inflammation, bronchoconstriction, mucus production, and as a result, the patient ends up coughing, wheezing, short of breath. And so these antagonists prevent them from attaching to the receptor cells and blocks the inflammation and relieves the symptoms of asthma. There is a black box warning on montelukast or Singulair about serious mood-related changes in behaviors, so please be aware of that. Another thing about Singulair or montelukast is that these are only for those who are 12 years of age and older. Can also be used to treat allergic rhinitis, at least Singulair can. And they do work rather rapidly, so around a week. But they are not indicated in an acute attack if somebody's already had a previous adverse drug reaction to this class of medications. and look at their allergies if they're allergic to iodine, so povidone, which is part of the PDI things that we use to clean skin with, lactose and titanium, because those are inactive ingredients that are found in those medications. All right, and some other things to be aware of are the adverse effects for Zoloton, so headache, nausea, dizziness, and insomnia. With Zafirlocast and Montelukast, they cause more headache, nausea, diarrhea. Of course, patients should check with their doctor prior to taking any medications when they're on these, so that we don't have any interactions, and need to make sure that you ask about liver function and assess liver function before and during therapy. All right, we're going to move on to our corticosteroids. So basically, corticosteroids are anti-inflammatories. That's what we use them for. We say used for chronic asthma, and that much is true. Somebody might be on chronic steroids to relieve the breathing symptoms. However, although we say they're not used for acute asthma attacks, they may be as an adjunct treatment in it, that if we're using systemic IV steroids. But if you're just saying, like, give them a bi-mouth steroid, no, that's not what we're talking about. If we have an inhaled corticosteroid, that's generally preferred over a systemic, as long as we're not dealing with like a life-threatening or very sick patient, because the exertion of the glucocorticoid effects will be just on the tissue that is being touched by it. So less systemic, more localized effect. If somebody's on steroids, if they're on oral steroids and also inhaled, might take some weeks before we really see the effects. And what do? Well, they stabilize the membranes. So basically the leukocytes. Remember, we said that the immune system is implicated in releasing those substances that cause inflammation. So corticosteroids can reduce inflammation and help the activity of those beta agonists like albuterol. So this is why you'll see it being given in those acute attacks. However, long-term use of systemic steroids does have adverse effect. And one of the most important ones that you hear about is Cushing's syndrome. So understand that the body does make corticosteroids. So if you're taking systemic corticosteroids, your body will stop producing it. It will see it already has enough, and too much steroid usage can cause Cushing's syndrome, and that's the one that's associated with moon face, buffalo humps, purple striae on the abdomen. And then if you are giving a corticosteroid and you withdraw it suddenly without tapering it, the person can actually go into a crisis where they have no steroids at all in their body, because remember, the body will not make what it's being given. But thankfully here, right now, we're going to be talking about the inhaled corticosteroids. So Pulmicort or budesonide, fluticasone, which can be through an inhaler, and fluticasone or Flonase is the intranasal. Mometasone, called Asmonex, which is, I've always enjoyed the Asmonex Twist-Tailor. I always thought it was fun to work with. So we're talking more inhaled corticosteroids. All right, so indications. Those who have bronchospasm, asthma, and again, systemic corticosteroids. So IV would be considered systemic as well as by mouth. Those are going to be for acute exacerbations or severe symptoms. Contraindications. So there are a few. So it's not sole therapy for asthma attacks. Remember, we're going to be giving albuterol. It is anybody who has a hypersensitivity to glucocorticoids, if they have candida, or systemic fungal infections. Remember, these are often used concurrently with beta adrenergic agonists. some of the adverse effects. So pharyngeal irritation, coughing, dry mouth, oral fungal infections. So oral candidiasis and dry mouth are going to be some of the most common things. And that's why we teach our patients about rinsing out their mouth and making sure everything's clean with their inhalers. Lots of drug interactions here. And I think that you should take a look at your textbook about what these actually can cause. But they interact with cyclosporin and tacrolimus, which you may or may not recognize those as medications that kind of damper the immune system to prevent rejection of organ transplants. Itraconazole, which is used for fungal infections, phenytoin, phenobarbital, rifampin, and again, can increase glucose levels. As we move on to the next one, we have phosphodiesterase 4 inhibitors. And if you recall, previously we talked about the cyclic levels, the camp levels, and how preventing their breakdown with phosphodiesterase, breaking them down, would be beneficial because it would allow more circulating camp level. And here is only one drug in the phosphodiesterase 4 inhibitor class, and that is roflumilast. And this basically decreases inflammation in the lungs. It's not used routinely. It is for those with life-threatening COPD exacerbations. It has some adverse effects listed here. It has the added ability to cause psychiatric symptoms as well. So remember that it is not a bronchodilator, and it is not going to treat any bronchospasm that's already begun. So it's going to be a need to use alongside other medications like the bronchodilators. Monoclonal antibodies like Xolair, Sinclair, don't they have nice names? Dupixent, which you'll see with some other different uses as well if you watch your TV commercials. But I like monoclonal antibodies in that I know how to pick them out of a crowd. They are super easy because they do say MAB at the end, if you can see here, monoclonal antibodies. So basically what these are doing is binding immunoglobulin E. They are injection. And monoclonal antibodies, I don't care which one they are, their claim to fame is that because of how they're modulating the immune system, they can cause anaphylactic reactions. So patients need to be monitored very closely for signs and symptoms that they are developing anaphylaxis. All right, so let's look at the nursing implications, patient teaching, things of that nature for basically our respiratory drugs. So we want to make sure our patients know to have a healthy lifestyle. One of the best things that we can do for our patients is have them avoid those exposures which are likely to cause bronchospasm. This means staying away from smoke and other irritants that are in the environment, allergens, keeping healthy, staying away from sick people, making sure they have adequate fluid intake to make sure that any of the mucus stays thin and movable. Take their puffers and things just as they've been taught, and definitely don't overuse them. Make sure our patients are getting their vaccines because these are very important, especially flu vaccine, pneumonia vaccine. We have COVID vaccines. We have RSV vaccines for those who are eligible. All right. Looking at the thorough assessment, we want to assess the patient's skin color, their vital signs, their respiratory rate, make sure that it's within normal limits. And if it's not, let's document. We want to know if our patient's getting better or worse. A good respiratory assessment, that means you actually have to put your stethoscope on their chest and listen to their lung sounds. If they're making any sputum, let's find out about it. I want to know color, consistency, any history of allergies and respiratory problems. Make sure you know what meds your patient is already on. And then, of course, smoking history. And remember for our kids here that they may not smoke, but mom and dad might, so they might be exposed to secondhand smoke. During therapy, make sure that we are monitoring our patients to see that these medications are working. that they have better breathing, so they have decreased shortness of breath, that they have better sounds for their lungs, decreased adventitious lung sounds, that they're not restless, that their anxiety is at a better pace, that they're able to participate in those activities that they'd like to do. And that's one of the best ways to find out about activity intolerance, is to ask your patient. Really, just ask them, are you able to do those things that you want to do? All right. And for any inhaler, make sure that the patient can self-administer it. We want to provide demonstration and get return demonstration back. Make sure they know the correct time and intervals for their inhalers, and how long to wait in between puffs, and if they have different medications, how long to wait in between that. I think the guidelines are about a minute between puffs and 5 minutes between medications. 2 to 5 for that, but generally we stick with the 5-minute rule. Gargle and rinse their mouth if they're having any inhaled steroids. Remember, they don't want to swallow that water, they want to spit it out. If they have multiple medications, use the bronchodilator first, and that makes sense. We want to open the lungs so that the next medication can get deeper into those lungs and exert its influence on that lung tissue. Spacers are very helpful if the patient can't coordinate the breathing with the inhaler activation, so make sure you have that potentially available, or ask the provider to order one if you need a specific order. Ensure that your patient can keep track of the number of doses in their inhaler. They shouldn't be running out. You don't want them to run out, especially if they're rescue inhaler. And how to clean their equipment. The peak flow monitor, peak flow meter, is a test that they will have to take routinely to monitor their disease. All right, so here we came at the end. Thank you guys for sticking with me. So I have this, gosh, I love these cartoons. This is Savage Chickens. He says, I'll huff and I'll puff and I'll blow your house down. Huff, cough, puff. Ah, forget it. I'll just tear it down with my claws. Have a great day.